Hello, my name is Laura Roberts, and for my research project, I am studying radial scars. What are radial scars? How they are seen on mammography, and how breast MRI can help with problem solving with how to follow up or not follow up on these benign lesions. A radial scar is a proliferative breast lesion that can mimic an invasive breast carcinoma due to its stellate appearance. Mammographically, RS appear as a radiolucent star-shaped lesion. On breast MRI, the appearance can be a bit variable. The journal article that I used for reference noted that out of 13 radial scars, only 7 were seen on MRI, and of those, 6 appeared as a mass and 1 appeared as a non-enhancement with regional homogeneous enhancement and type 3 kinetic curve. They're most common in women ages 41 to 60. The prevalence is 0.1 to 2.0 radial scars for every 1,000 screening examinations. The addition of newer breast imaging modalities has made it easier to visualize this architectural distortion, which can either be a malignancy or a high-risk benign lesion like a radial scar. Radial scars in general are rarely associated with atypia or ductal carcinoma in situ and are therefore most often a benign lesion. Yet when a RS is noted at biopsy with other high-risk lesions such as atypia, studies have shown that cancers are often found in the periphery of a radial scar, and there can be concern for sampling error during a core biopsy. So that's why when atypia is found at the time of a core biopsy, a surgical excision is recommended due to an upgrade rate of 2.8 to 6.7%. Mammography is breast imaging that is performed on dedicated equipment that uses a much lower range of kilovoltage compared to general radiography. The use of low kV permits the differentiation of structures in homogeneous soft tissues in the breast. The patient's breast is placed on a digital detector and a plastic plate is brought down onto the breast. This helps to keep the patient from moving, evens out the breast tissue, and the added compression also helps to reveal malignancies during imaging. In the past 25 years, advances have been made in mammography with the introduction of digital mammography and now 3D tomosynthesis. Mammography, particularly 3D, has led to the discovery of mammographic findings that would have normally gone undetected in 2D studies. Not always is this helpful, especially when a core biopsy yields a high-risk benign diagnosis. Breast MRI uses a strong magnetic field gradients, and radio waves to generate images of the breast. During a breast MRI, the patient lies prone on the MRI table, and the patient's breasts hang down through an opening in a breast coil for scanning without being compressed. A dedicated breast coil is used to give high-quality images by acting as an antenna during the MRI scan. Mammography is the gold standard for breast imaging, especially screening. With the addition of 3D imaging, there has been an increase in the detection of smaller lesions that would have normally gone undetected in a 2D image. When these lesions are sampled and pathology confirms RS, what do we do? What do the radiologist and surgeon do to manage these high-risk controversial lesions? Pre-surgical consult and excision? Follow with breast imaging? There is a concern with overtreatment of breast findings with too many surgical excisions without any added value for the patient. There needs to be a balance to avoid the unnecessary costs and complications associated with surgical excisions. The use of another modality to evaluate and problem solve these radial scars to determine a benign appearance would help with treatment planning. Breast MRI can help as a problem-solving tool for inconclusive clinical or mammographic findings. In my research, I found a study with 175 patients with mammographic architectural distortion that had MRI after MAD, was seen on their mammogram. Of these 175, some had core biopsy, some had a surgical excision, and some were followed with imaging. The results were mixed. MRI proved to be a good problem-solving tool with a high negative predictive value, suggesting that patients with a negative breast MRI can be followed safely without surgery. Unfortunately, there was a low positive predictive value and specificity, 30 and 67% respectively. Here we have 2 images showing a mammogram with the green arrows pointing at the architectural distortion and that was core biopsied and deemed to be a radial scar. Here is a breast MRI showing a radial scar. And in conclusion, the incidence of radial scars seen as mammographic architectural distortion has been increasing with the use of 3D tomosynthesis. Radial scars are a proliferative breast lesion but are high-risk benign lesion, and they can mimic an invasive cancer as it appears as a stellate lesion on mammography. Additional modalities such as MRI can be used for problem solving to determine management of these high-risk benign lesions. The goal is to avoid unnecessary surgical excision, which carries extra costs and risks. Surgery is not always the best option and should be avoided. And here are my references. And thank you all very much for your time.